Bismillahirrahmanirrahim. So today we are going to study about the selective serotonin reuptake inhibitors. So let's start. So selective serotonin reuptake inhibitors include the drugs like the citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. And we have already discussed the way how to remember all of these drugs in the lecture about the classification of the antidepressant drugs. So kindly watch that lecture. So let's talk about some of the important points regarding selective serotonin reuptake inhibitors. So the first point is that the prototypic drug of this class is the fluoxetine. Fluoxetine is the prototypic drug of this class, i.e. SSRI. The second point is that they are about 300 to 3000 fold greater selective for the serotonin transporter. The third point and the important point is that they have very little blocking effect on the receptors like the muscarinic receptors, the alpha-adrenergic receptors, and the histaminic receptors. And the important point and the good point is that all of the side effects which are related to such kinds of receptors will not be present in the SSRIs, like the orthostatic hypotension, sedation, the dry mouth, and the blurred vision. They are not be present in the SSRIs in contrast to TSAs, which have all of these side effects. And the fourth important point that they do not cause any weight gain, and the CNS and the CVS related side effects like the convulsion and cardiac arrhythmia. So all of these important and good points make the SSRIs as the first line drug for the depressions. So all of these are the important and good points of the SSRIs. Now let's talk about the pharmacokinetics of the SSRIs. So we will discuss them under four headings. The ADME, A for absorption, D for the distribution, M for metabolism, and E for the excretion. So let's start. So the first one, the absorption, that they are all well absorbed from the GI tract after the oral administration, and the food does not affect the absorption of the SSRIs except for the sertraline. And the sertraline, the food increase the absorption of sertraline. The second important point is regarding the distribution, that they are all well distributed throughout the body, especially the brain, which is the main site of action for the antidepressant SSRIs. And the third important point is regarding the metabolism. So the metabolism occurs in the liver to inactive metabolite, mostly to inactive metabolites by the cytochrome P4 enzyme. And this cytochrome P4 enzyme is very important because about 7% of the Caucasian population lack this cytochrome P4 enzyme and are called the poor metabolizer. So we have to keep in mind the poor metabolizer are those who have lacking this enzyme, and we have to decrease the dose. The other important point that they have a plasma half-life that range between 16 to 36 hours. Most of the SSRIs have a half-life of about 16 to 36 hours. And the excretion, they are mostly excretion through the kidneys except for the paroxetine and the sertraline. Which are excreted through the fecal route. Now let's talk about the two important features of the fluoxetine which make it different from the other members of its class. And the first one is that they have a much longer half-life of about 50 hours in contrast to the other members, which I have already said they have a half-life of about 16 to 36 hours. They have a half-life of 50 hours. And the second point is that they are present as a sustained release preparation, and we have to give it only once per week. First one, they have a much longer half-life of about 50 hours, and the second one, they are present as sustained release preparations which are given once per week. The third point is that it has an active metabolite in contrast to the other members which have inactive metabolite, which is known as the S-norfloxetine, and it is as potent as a fluoxetine but has a much more half-life of about 10 days. In contrast to fluoxetine, which have a half-life of about 50 hours, and other members which have a half-life of about 16 to 36 hours. Now let's talk about the pharmacological actions of the SSRIs. So before talking about the pharmacological action, we have to know about the physiology. So let's consider this is the first nerve ending, and we will draw another nerve ending, second nerve ending. Now the first nerve ending, as we can see, this consists of a vesicle consisting of serotonin, and after receiving the signal, these vesicles release this serotonin into a cleft which is known as synaptic cleft. This is synaptic cleft. After releasing this serotonin, there are three possibilities for this serotonin to work. The first, it acts on this serotonin receptor on the second nerve ending. First one. The second one, it is taken back into the first nerve endings to a receptor which is known as the selective serotonin transporter. And the third possibility is that it acts on the autoreceptors. And what does it do on the autoreceptors? We will discuss in the other slide. So the first mechanism, it acts upon the what? The serotonin receptor. The second one, it is taken back into the nerve ending for the reuse. And the third one, that it acts upon the autoreceptors. Now what does this selective serotonin reuptake inhibitors do? It blocks this receptor. It blocks these receptors and prevent the reuptake of the serotonin into the nerve ending. And this will in turn increase the concentration of serotonin in the synaptic cleft. And upon increasing the concentration, this increased concentration will in turn affects upon these serotonin receptors and will produce its effect for a long time. And this is the mechanism by which the selective serotonin reuptake inhibitors do. As we have already discussed, it blocks the reuptake of serotonin to the neuron and thus enhance the availability of the serotonin at the receptors in the CNS. What is the important point to keep in mind that all of the antidepressants take about 2 to 3 weeks to produce its beneficial effects. And it is mainly due to the presynaptic serotonin autoreceptors, as we have already discussed. For the ability of the serotonin to work on their own receptors, serotonin receptors on the autoreceptors, and are taken back into the nerve ending. So increase in the serotonin in the synaptic clefts will increase the stimulation of presynaptic serotonin receptors initially. As we have already discussed, these are the autoreceptors, and this is the first nerve ending consisting of the autoreceptors, and this is the second nerve ending consisting of the serotonin receptors. Now, what does this serotonin do in the synaptic cleft? That it increase the stimulation of these autoreceptors, which in turn give the signal to the nerve endings that much more increased serotonin, is present in the synaptic cleft, and thus decrease of the secretion of the serotonin into the synaptic clefts. So there will be a decrease in the release of these transmitters due to a negative feedback mechanism, as I have already discussed. But later, this receptor is desensitized after some time, and the antidepressant effects coincide with this desensitization of various receptors, and it takes about 2 to 3 weeks. So it is the important point to keep in mind that we have to wait for about 2 to 3 weeks for the beneficial effects of all of the antidepressant drugs. Now, what are the therapeutic uses of the antidepressant drugs? So the first one, the primary indication is the depression. The second one, it is also used for the obsessive compulsive disorder. The third one, can be used for the panic disorders. The fourth one, for the generalized anxiety disorders, post-traumatic stress disorders, for the social anxiety disorders, For the premenstrual dysphoric disorders and for the bulimia nervosa, only fluoxetine is recommended. For the depression, obsessive compulsive disorders, panic disorders, generalized anxiety disorders, post-traumatic stress, social anxiety, premenstrual dysphoric disorder, and the bulimia nervosa, for which only fluoxetine is recommended. Now let's talk about the side effects of the SSRIs. So the first side effect that it causes the headache. The second that it can also cause sweating. It can also cause anxiety and agitation. It can also cause GI related signs and symptoms like nausea, vomiting and diarrhea. It can also cause weakness and fatigue. Sleep disturbance. And the sleep disturbance may be that it increases the sleep inducing, or it decreases the sleep. So paroxetine and fluoxamine, they increase the sleep because they are sedating. So they are much more useful in the patient which have difficulty in sleeping. Conversely, the drugs like the fluoxetine and sertraline, they are most useful in the somnolent people which have increased sleep. So in order to reduce their sleep, fluoxetine and sertraline are given because they have anti-sedating effect. The other side effect that it causes suicidal ideation, and is much more in the children and teenagers. This is an important point. Only fluoxetine is recommended for childhood depression. It also causes sexual dysfunctions like the decrease in the libido, delayed ejaculation, and the anorgasmia. It also causes serotonin discontinuation syndrome, and the most probable signs and symptoms are the serotonin related discontinuation syndrome are include the headache, the malaise, flu-like symptoms, agitation, irritability, nervousness, and changes in the sleep pattern. That's all for today.